How many employees are there altogether in your system? Where are you at percentage-wise? You hit 1%? No. So there's lots to do. And I'll tell you one of the pathways that we experience about how to do that in times when the money is shrinking. Today, 62% of our employees are peers working in dedicated peer support jobs. You know, they're not just acting as the driver or the receptionist or working in the file room. They're providing peer support with their peers. Some of the results, we talked about the seclusion and restraint elimination. And I'll tell you a little bit more about what happened in the county hospital when we added peers to the teams. But the first thing that we noticed was the peer support specialist's own recovery grew rapidly. Now, this was an amazing thing. You know, we thought therapy was the answer. We thought counseling was the answer. We thought treatment was the answer. You know what it was? It was a meaningful job. You know, it was a paycheck. It was the self-esteem that came from making a contribution. So this year, a few months ago, we did an anonymous internet survey of all our peer employees. And we asked them a series of questions, and what I was really wanting to find out was, what's the impact of going to work? What's happened in your life? We had 253 employees that responded, 70% response rate. Prior to their employment with us, 2/3 of them weren't working, didn't have a job. Over 1/3 of them had been unemployed for more than 3 years. Long-term unemployment on the part of many. The average number of hours worked was 30 hours, so we have a mix of full-time and part-time employees, depending on what the person wants and what works for them. 20% of the people in the group went off their disability benefits, gave up their disability pensions. Now that is revolutionary. I didn't know this could happen. I don't know how it is here, but in the US we see less than 1% of the people on disability payments going off disability. Another 37% reduced their disability payments. 45% went off Medicaid, the public health care system, discontinued housing subsidies, food stamps, and so forth. Financial impact of this should be front page news. I think we played a trick on the system because $8 million in salaries for our peer employees that was previously going to their mental health treatment that's now going into their paychecks. It's still mental health money. This really improves the quality of their life. $1.2 million paid in income taxes. $500,000 of reduction savings in disability payments. This is a no-brainer. But some of the other things that they reported had happened. 87%, helping others has helped my own recovery. I feel more confident. I'm more emotionally stable. I'm more satisfied with life in general. 68% interested in future career opportunities. That's what recovery is, moving on. Able to connect with family. Socialize with friends. Begin saving money. Taken a paid vacation. How cool is that? One person says, I went to the Grand Canyon. I had someone house sit for me because I have a dog, and I drove my own car. That's what recovery is, right? Peer support specialists help others recover. I've talked a little bit about that. When we put the peer staff on the 9 units at our county hospital, now it took quite a bit of talking and a long time to convince the hospital that this was a good thing to do, but we had 2 peer support specialists working on each unit every day. They were providing peer support. They did an orientation to recovery meeting, and they did something they called a discharge recovery plan, which was an effort to really work out the practical issues involved in leaving the hospital because they knew what it was like not to know who was going to pick you up, not to know what was happening to the mail in your mailbox or the backpack behind your case manager's desk, right? And after a year, the hospital reported a 56% reduction in readmissions. Now, this was not a scientific study, but the only thing that had changed in that hospital was the peers were there. The reduction in seclusion and restraint in the hospital happened because of the increased accountability that shows up on teams when someone with that lived experience speaks up. peer support specialists help the system recover. Now, if you're working in a hospital, if you're working in a crisis service, you may never see people that have recovered, and your perspective gets off balance. So as we begin to have peers, people in recovery, showing up every day, contributing and making a difference on those teams, the staff begin to say, oh, recovery is real. There it is. Look at John, right? Confronting our own stigma. We know there's more stigma in the mental health profession than anywhere else. Folks, this is just sad. But we see it and we hear it all the time. So having peers on the team, having peers in the planning sessions is a way to help correct this. People can change their whole identity by remembering who they are. They can take on a new role. That role might be student, like you're experiencing in your recovery colleges. That role may be employee. That role may be colleague. So we see people showing up and begin to value their contribution. And it saves money. Here's one example from our early experience of how it saved money. When we installed our living room program, which was our peer-run crisis alternative, where people could be a guest, experience overnight hospitality, hear the message of hope and recovery from someone who'd been there, we stopped putting people in the hospital because they found another way. And we tracked this for 15 months, and guess what? In hospital savings alone, we saved over $10 million. Now, our system was able to redirect those dollars to build more recovery and peer-oriented services. So 63% of our workforce is there because we did things like this, that we're then able to fund and support new recovery initiatives. Last year, we were invited to join an initiative in Tacoma, Washington, which is outside of Seattle, where the funder was committed to transforming the crisis and emergency system. And so we opened our Recovery Response Center up there as the front door to the system. We created a way for police to bring people to us instead of to jail. And this is what was reported now, 1 year after this happened, a 15.5% reduction in hospitalizations, $1.5 million saved. A 32% reduction in compulsory treatment, $2 million saved. A 32% reduction in readmission rate, and a reduction in the length of stay in the hospital from 19 days to 12 days, $4.4 million saved. This is dramatic. This is what happens when peers join the team. This is what happens when we take on a vision truly of recovery. So now they've invited us to open and staff our peer recovery team. So peer recovery team goes and meets with people that are in the hospital, helps them get out, and helps them connect to recovery-oriented services in the community, and they work with people for about 3 weeks. It's kind of a peer bridging concept. This is what was reported. We served 120 people in 12 months. This cohort of 120 people had 131 hospital admissions the 12 months before they saw the peer recovery team. After they were involved with the peer recovery team, there were only 23 hospital admissions. Now, what's fascinating to me is we didn't try to do this. We didn't set out with this as our goal. We simply wanted to provide peer support, share our experience of recovery with people, help them get connected to the services and supports they needed in the community. But this is what happens. This is a natural consequence of having peers on the team. So, we don't have enough money and we're going to get less money. But at the same time, maybe we do have enough money. We got to change how we're using it. And this is the challenge, I think, to our field, is let's get smart about how we're using the resources we have. It's going to make change. It's going to be disruptive. And things are not going to be the same. But it's for the people because that's what we're about. Quickly, some tips for success. It takes organizational commitment. It takes the leaders to take this on. If they don't, it's not going to happen. I can tell you how I did that. I did the training. I wrote the training. I spent the time with the staff. I still do that. I love that. So quality training prior to employment of peers, we see people hiring peers, but they don't have the peer support skills because they haven't been through the training. All staff have to have recovery training. Everybody has to get on board of this. We need to be able to embed this as part of how we do business. We need training for supervisors and leadership, and all of these things you're doing here. I'm just so thrilled. We need to create job-specific peer roles, and sometimes we just created a new role or a new task that the peers could do so that they would have something unique that distinguished them from other members of the team, right? All within the context of the peer support practices and principles. We need the tipping point. We need to do this as quickly as we can, and we need a career ladder. So without an opportunity to go to full-time work, without an opportunity to take on more responsibility, without an opportunity to become a team leader or a supervisor, what happened with me is the peers went somewhere else. You know, they went back and got case manager jobs, or they went on to someone, and we were losing the contribution that they were making so powerfully. So we got to have that career ladder. We need parity for peer workers. And that's in terms of supervision and support, performance expectations, pay, promotion, ethics. It's across the board. Early on, our peer staff said, don't treat us any differently than anybody else. You know, we need parity in terms of pay, but also parity in terms of attendance, productivity, documentation. We can take this on. And of course, we want to remember this is real work. They're equal members of our team. They're our employees. They're our staff. You know, they're not our patients anymore. It's not sheltered work. So, yes, we can. We can take this on. I say, be courageous, be generous, give your gifts, and create hope, right? Sincere appreciation for positive feedback to the person and appreciation of their contribution. So, the movement is happening. You've landed. And I want to learn from your experience as we begin to share ours, because this is truly extraordinary times we're in. Thank you.
I guess what I want to start with is actually saying that for those of us who have lived with mental health problems, peer support is nothing new. In my experience, it used to happen in the smoking rooms of hospitals, you know, where you're well away from staff. Now it seems you have to go and shiver outside. So I think if we look back in British history, we can actually see the first peer support network was set up in the 1860s, actually, for those of you who are familiar with it, the Alleged Lunatic Friends Society, set up way back then. And I think we've got to remember, when we're talking about statutory services, that actually there's loads and loads of formal and informal peer support networks, self-help groups. They exist, and I think they have a really important role to play. I suppose we've also, if any of you work in addiction services, addiction sort of got onto this notion that actually someone who'd walked a similar path could actually give maybe more than someone who hadn't. Has been around for a long time. And I suppose the other thing is we've often seen peer support workers in non-statutory services. That we've also got a very few peer-run services. We're not good in England at handing over the money or the keys. They might spend it wrong and they might forget to lock up. But never mind, Leeds Crisis Service have actually persuaded them a bit, and some others. But what we've been really bad at doing is including the expertise of lived experience in our mainstream statutory services. And if we think about it, the other things I've talked about are essentially small scale. The biggest non-statutory organisation, voluntary sector organisation in this country, I understand serves about 7,500 people a day. The mental health trust I worked for until about a year and a half ago in southwest London, in just that bit, served 15,000 people a day. And I think we've just got to get some idea of some of the scale of things. And unless we can break into that bastion of the NHS, then I think we're always the NHS is really good at putting extra bits round the edge, so long as it doesn't affect the core. And I think the challenge of this, what we're talking about today, is how you get in there to the core, you know, the Trojan horse, if you like. Sorry, I'll stop doing all that. Right, okay, why has it been hard? Well, I think we've got to remember that there are actually a number of structural barriers in this country. Come across the Clothier report? Until 2002, there was guidance in the NHS that you should not employ anyone within 2 years of having received treatment for a mental health problem. Now, that was frankly illegal for 7 years, but it still existed. And believe you me, it still lurks around in a lot of occupational health rules. I did have a little cause to take one occupational health service to the Equalities and Human Rights Commission, and that was 2 years ago. I think we've still got this notion that mad people are dangerous in the NHS. Of course, we've also got highly professionalised services. What amazed me when I first visited the States in the early 90s was that they'd got an assertive outreach team that had an eighth of a doctor, one nurse, one social worker, and a load of care managers, I think they called them there. We couldn't do that, could we? Who'd be the care coordinator? We've got these lovely professions. There's 5 of us. We're the guilds, aren't we? Psychiatrists, nurses, social workers, occupational therapies, and nurses. There's a few others who are trying to get in, but those are the guilds, and we've got the situation sewn up, haven't we? We've defined what you can do. You are not allowed to coordinate care unless you have a qualification. We've got a grading system with band 5, haven't we? It's called a band 5 bar. You can employ anyone you like in bands 1, 2, 3 and 4, but you've got to be a professional or a graduate to get into band 5. I know some people, it's right, there's all sorts of things going on to break down some of these, but these are the sort of traditional things we've got. We've also, of course, got professionals providing both professional and non-professional tasks. I'm a clinical psychologist. I went feral, I'm never so sorry. But I was a clinical psychologist. Now, I think back to the times when I was a clinical psychologist. How much time I actually spent doing psychological therapy, which I'd been trained for 25 years of state education, and how much time I spent helping people to find somewhere to take the cat to the vet. Chatting, I could call chatting therapy if I wanted, but it was chatting. Trying to fix the washing machine.